afternoon, everyone, and welcome to the 30th installment or episode of the University of the Philippines and the Philippine Health Insurance Corporation's Stop COVID Deaths webinar series. I'm Dr. Raymond Sarmiento, Director of the National Telehealth Center, the National Institutes of Health, University of the Philippines, Manila. And as always, and as found in our previous webinars, we will be employing the virtual Grand Rounds format. But for Season 3, wherein we are now, we will be interspersing all of these virtual grand rounds with special topics, so please stay tuned for developments, especially for our continuation of the virtual international conference on medical education, which we will be conducting very, very soon. And as always, it's my pleasure and honor to share the hosting duties with the dear friend and mentor, my partner in crime, Dr. Susie Pineda Mercado, who is the Special Envoy of the President for Global Health Initiatives. Dr. Susie.
Thank you very much, Raymond. And I just like to greet everyone. Good morning, good afternoon, good evening, wherever you are. I guess some of you will not be able to join us on the webinar, but are watching us on the playback on TVUP's YouTube channel. So welcome. We've got a very exciting topic today. I think just coming out of these recent typhoons has been very difficult, but COVID is still there, and it's something we continue to learn about and talk about. So stay with us today. I think we've got a great session this afternoon. Raymond.
Thank you, Dr. Susie. And as Dr. Susie mentioned, we are extending po our sympathies and our prayers po sa ating mga fellow kababayans at mga kasamahan po and colleagues po who nasalanta po ng bagyong Rolly, bagyong Ulysses po. At lalo na po doon po sa mga nakatira po sa Quezon City, sa Marikina, they are all over the news. And if you would look at how their plight really has moved a lot of people, especially those who lost their homes, lost their jobs, lost their sources of income, it really is very heart-wrenching in that sense. But tuloy po ang laban, and we are here to be able to help out, especially for those who may be watching us from their phones over at the evacuation centers at iba pong mga lugar kung nasaan po sila. Maraming salamat po sa pagsubaybay. And for those who are joining us for the very first time for our virtual grand rounds, we are using this format in terms of having a very special case be presented. And then we will have our main discussant, who is often an attending or a consultant over the Philippine General Hospital, and also for a more multidisciplinary view of things. We have been inviting several other resource persons, and for today we have a very special lecture presentation po from our resource person over from the Department of Health. And for those who are asking, those who will be eligible for receiving their electronic certificates, sila po yung nagstay po sa webinar for at least 50% of the duration. At for those who will be receiving the certificates, sila rin po ay makaka-receive ng kopya ng lecture presentation in the form of the PowerPoint presentation of our resource person. So mag-ingat po kayo kung paano nyo po ini-input ang inyong mga pangalan para po sa inyong certificates, dahil po kung ano po ang pangalan na iniligay po ninyo, kung ano po siya in-spell sa registration link, ay ganun din po siya mag-a-appear sa ating electronic certificates. And I'd also like to thank the very hardworking team behind the Stop COVID Deaths webinar series, the University of the Philippines System, the Philippine Health Insurance Corporation, over at the National Telehealth Center, National Institutes of Health, and at UP Manila Office of the Chancellor. We also have the College of Medicine, the Philippine General Hospital, at ang ating technical support from the Information Technology Development Center, IDDC. And always din po sa mga nanonood po sa YouTube at kung manonood po kayo sa playback ng ating episode na ito and all of our previous 29 episodes, lahat po ito ay nasa YouTube channel ng Internet Television Network of the University of the Philippines, which is TVUP. Dr. Susie?
Raymond, is that a growth chart beside you?
Yes, that's a growth chart for my daughter po. And I couldn't pull it out because baka po masira yung ano po eh. Yung dingding.
I was just looking at it. I said, just a light moment for all of us. All right. So we're going to talk today about a 90-year-old patient who uh, got sick or developed symptoms of a stroke, I think, and but was rejected 7 times in 7 different hospitals. And for that reason, we will be talking not just about the clinical management of this person, but how the system is working. Because, to get rejected 7 times if you're in a very serious situation is not just neglect, no? This is already, what should I say, a failure of the system. Unfortunately, there are measures that have been taken to correct the referral system, and we're going to hear a little bit more about that. But it's appropriate also that our introductory speaker is somebody who understands the whole system, has actually been running the entire emergency systems of the country when he was Undersecretary of Health, and has been a very strong supporter of this webinar series, who also happens to be the Executive Vice President. So we'd like to welcome somebody you know well, Dr. Ted Herbosa. Ted, welcome to your webinar.
Thank you, Dr. Susie Mercado, the President's Special Envoy for Global Health, Dr. Raymond Sarmiento, our Executive Director of the UP-NIH National Telehealth Center, all the speakers and panelists, all the loyal followers, and even the first-time viewers of this Stop COVID Deaths webinar. A pleasant good afternoon, good morning, good evening to everyone. Stop COVID Deaths was conceptualized by Dr. Susie Mercado when she was still with the PhilHealth board during the early part of this pandemic. After a webinar to help disseminate information on COVID-19, Susie contacted me with an idea of a webinar series to keep health professionals and the public informed. I immediately knew that at that time, with so much disinformation on the net, this was badly needed by our colleagues. We saw also the work being done by our specialists and academicians and researchers at the UP-NIH, the UP Philippine Genome Center, and the UP-PGH, which at that time had volunteered to be one of the 3 COVID referral hospitals in the NCR at the behest of many of the health workers and doctors there. I informed Susie that there were 2 groups at UP that held regular webinars for the UP community. First, there was the National Telehealth Center led by its director, Dr. Raymond Sarmiento, and they had a long history and wide experience having done health-related webinars regularly, even before it was even popular. The other was the Office of the Vice President for Public Affairs under Vice President Neni Pernia and AVP Rica Abad, with TVUP, an entrenched unit at the Office of the President of UP that had previously been created with so much produced content on its YouTube channel called TVUP. Seeing this big picture, my office as the Executive Vice President helped combine these 2 UP units to team up, and the product has been this excellent educational webinar series entitled Stop COVID Deaths. Of course, the partnership with PhilHealth had indeed helped in bringing this knowledge-sharing virtual event to a nationwide audience and eventually an international audience. Allow me to congratulate this whole team for its great contribution done with minimal support and financing and very much fueled by everyone's passion to inform and teach. I have witnessed the attention to detail in terms of topic selection, pre-production, production, and post-production activities that the whole team had contributed to produce quality webinars. Of course, as EVP, I still have to sign off some of the costs. Indeed, the next challenge is to continue to support these valuable efforts of people who were never together in a single place during all these episodes. All phases of production were done online through video conferencing and emails. Indeed, this is the new normal, and this effort is an excellent and important one for the University of the Philippines and PhilHealth. As we discussed today, a more significant aspect of the health system regarding emergency referrals and hospital networks, we will see that we have major gaps in our health system prior to the pandemic, and we have been challenged to further strengthen the health system under the UHC implementation and COVID-19 pandemic, and struggle to improve health systems with the need for better leadership and health governance to function efficiently. For the webinar series, we are now in the middle of our session 3, wherein we tackle specific clinical cases using virtual grand routes format. Today, we have a special case of a patient experiencing seizures while being diagnosed with COVID-19. And just like our previous virtual grand rounds, we will discuss our case with a multidisciplinary approach, focusing on clinical as well as public health aspects of this case, and how the patient may have been saved through effective coordination within the proposed service delivery network as stated in the Universal Healthcare Law. Let's all sit back, listen, and contemplate on this case as we strive a new normal for the Philippine healthcare system. I also invite the faculty listening to use the materials and videos at TVUP for their online learning modules. If you have not visited it yet, please do so by just searching for TVUP and the welcome to on the YouTube channel, on the YouTube, and welcome to a world of content for all our learners and faculty out there. Let me shamefully advertise my series there as well, called Health Issues. Again, congratulations to the Stop Death teams and all the people behind the scenes that make this happen every Friday for the past 30 weeks, and then make it possible to be viewed and reviewed at the TVUP channel on YouTube. Let's all watch, listen, and learn from the experts that we have invited today and address all the important issues of universal health care and health system strengthening. Mabuhay, and let's all heal as one.
Thank you. Thank you very much, Ted, for that uh, historical that history of this webinar series. Parang parang it was so long ago, no? I don't know if it was long ago or parang hapon lang, but anyway, we also want to thank you for all your support behind the scenes and for being with us today, because today we are going to ask you to be a reactor, and we're going to ask you to comment a little bit about how we can improve referral systems. So we're looking forward to your presentation, and hopefully these discussions help not just the clinicians but also the decision makers, and you are in a very important position to, as a special advisor for the National Task Force, to influence how the systems can be improved. So maraming salamat. Thank you very much, Ted. So Raymond, over to you.
Thank you so much for that, shall I say, invigorating message from our Executive Vice President, Dr. Ted Herbosa. At this point, may we have our polls, which serve as our pre-test question po for our webinar. And as always, the correct answers will be provided by the resource person who nominated these questions towards the end of the webinar. I'll read the questions po, and for our attendees who are now numbering 157 for this webinar attending in Zoom, please key in your selected choices po. For number 1, true or false? An 80-year-old female, previously independent in all activities, was brought to the hospital for recurrent generalized tonic-clonic seizures lasting 2 minutes for each episode, occurring 10 times in the last 2 hours. Patient has been unresponsive since the first seizure episode. Patient then should be managed as a status epilepticus. So more and more of our attendees po are keying in their answers. A lot of them are choosing true as their answer of choice po. But while we are waiting for the others to type in their selected answers po, may I do a shout out of all of our registered attendees all the way from the Northside Doctors Hospital in Bantay, Ilocos Sur in Ilocos Region, from Gapan District Hospital, Gapan City in Nueva Ecija, from Pinamungahan Rural Health Unit in Cebu. We also have those attending from Ciudad Medical Zamboanga in Zamboanga City, and from General Santos Doctors Hospital from General Santos City in Soc-Sargent. Internationally, we are also being viewed from the Higher Institute of Health Specialties, Ministry of Health, from Muscat, Oman, from the Balay Kesehatan, Penerbangan, Jakarta, Indonesia, and our regular from the Niagara Falls, Ontario, Canada. Maraming salamat po sa patuloy po.
Raymond, there are still some others here in the chat box, no? So,
oh yes, go ahead, Dr. Susie.
Negros Occidental, Calibo, Aklan, Iloilo, Negros Occidental, Tondo, Manila, BF Homes Parañaque. So I guess we might be missing out on some of our regular participants in the National Capital Region.
Yes.
But because we expect, people to be very busy. But just the same, we know that most of you who won't be here, are not here right now, will probably join us on TVUP. So go ahead, Raymond.
Correct po. And we'd like to really extend our deepest appreciation for those who still are able to join us for today's webinar. And for our second question, it states, which among the following is the most commonly associated with myoclonic status epilepticus? We have 4 choices. Choice A, septic encephalopathy. Choice B, anoxic encephalopathy. Choice C, COVID encephalitis. And choice D, acute cerebrovascular infarct. So dito po sa pangalawang question, medyo kalat-kalat po ang pagpili ng tamang sagot ng ating mga attendees. So please stay tuned until the very end of this webinar para po sa tamang kasagutan. And for the introduction of our main speaker, I'll turn the floor over to Dr. Susie.
Okay. Well, before we do that, Raymond, we're gonna have a video first, right?
Oh, yes. Okay, sorry. May we call on TVUP for the video that shows po just the context for our case study for today entitled Seizures and COVID-19.
Miguel, 90 years old, is a retired insurance salesman. A former smoker and alcoholic beverage drinker. He most of the time stayed home and hasn't traveled for quite some time. One afternoon, he was taking his usual daily walk in his yard when he felt a sudden dizzy spell. Then he started to feel his head aching. While looking for a hospital capable of managing the patient, they received news that the nasopharyngeal swab COVID test turned out positive for SARS-CoV-2. The patient at this time was progressively more dismayed, able to speak in phrases, with beginning restlessness and irritability. He was brought to several hospitals, all of which were unable to accept his admission prior his arrival to BGH.
Okay, thank you so much for that video to set the context for our case study for today. But before Dr. Susie introduces our case presenter, I'd just like to share the results of the pre-webinar questions po. We have 85% of our attendees choosing true for the first question, and for the second question, it really is a three-way tie essentially between septic encephalopathy, anoxic encephalopathy, and acute cerebrovascular infarct, with acute anoxic encephalopathy gaining the most choices po. Dr. Susie.
Okay, thanks a lot, Raymond. So I'd like to introduce our presenter for today. She is a fellow at the Department of Neurosciences of Philippine General Hospital, and we are very honored to have with us Dr. Athena Antonio. Dr. Athena, welcome to the webinar.
Hi, Doc Susie. Thank you for having me here. I'm really excited to share this case with you.
Okay, so before you start, Athena, did you get to see this patient?
Yes, actually, although I got to see this patient when he was already in the ICU, not during his short stay in the ER.
Right, and from the history, what we know is that it seems like he had symptoms of a stroke, but then he also tested positive for COVID somewhere, but several hospitals would not accept him. So by the time he got to PGH, what was what was said to be his condition?
Actually, when he got to the ER, when we received the endorsement for this patient, as he got to the ER, he was already in respiratory distress. So they already intubated the patient the moment that he was received at our emergency room. And the events went downhill after that. Although intubation
Okay, I think we lost Athena for a moment
the
there.
patient spent in
Okay.
respiratory distress without adequate medical attention led to prolonged lack of oxygen in the brain.
Okay, so when we named this webinar, we said it was about seizures, no? But actually, the seizures were later already in the hospital. So
Yes.
go ahead, Athena. Please make your presentation. Go ahead.
Okay. I'll share my screen.
Go ahead.
Okay. So, good afternoon, everyone. I'm here to tell you the story of PM, a 90-year-old male right-handed retired insurance agent widower with 8 children from Binyan, Laguna. He is independent in all ATLs and is able to climb a flight of stairs comfortably. He was brought to our institution for a chief complaint of difficulty of breathing. Symptoms actually started 1 week prior to admission with undocumented fever and generalized weakness. At this time, there was no cough, difficulty of breathing, chest pain, or diarrhea. The symptoms persisted and consult was made at a private hospital initially where a chest x-ray was requested. And results of this chest x-ray showed bilateral pneumonia. He was then tagged as a COVID suspect and advised admission. They opted admission 4 days prior to consult then at the local hospital due to financial constraints. And there he was managed as a COVID suspect and started on ceftriaxone, azithromycin, paracetamol, and omeprazole. 2 days prior to admission, on his second hospital day, he began to have symptoms of difficulty of breathing. At that time, he was still able to speak in sentences, but his dyspnea has been worsening progressively. They were advised the need for transfer to a different institution that would better attend to his worsening pulmonary status. And so the patient and the family came to look for another hospital that would be able to address the patient's condition. And on the day of admission, while looking for the hospital, they now received a call confirming his COVID positive status. En route, the dyspnea worsened further and he started to become irritable, restless, and eventually unable to speak. He arrived at our emergency department He arrived at our emergency department already in respiratory distress with stable blood pressure of 110/80, heart rate of 85, but tachypnic with an RR of respiratory rate of 30s, then a febrile at 36.9 and desaturated at 75% O2 sats. He was then intubated. However, post-intubation, he was referred for bradycardia and he was seen unresponsive to a dose of atropine, and eventually went into cardiorespiratory arrest. Spontaneous circulation was returned after 2 minutes of ACLS. At 9 a.m., however, the following day, more myoclonic jerks of the face and both extremities were observed, and upon admission to the medical ICU, diazepam was given. However, even repeated doses of this medication resulted only in temporary resolution of the myoclonic jerks. Hence, a referral to the adult neurology service was made. For the review of systems, it was pertinent for tupelo orthopnea, fatigability, and the following bladder symptoms. He has no known epilepsy or prior seizures. He has a chronic stroke that presented in 2018 with elevated blood pressure with no associated focal deficits, for which he was started on aspirin that he took for only 3 weeks. He was recently diagnosed with benign prostatic hypertrophy, and he completed treatment for pulmonary TB in 2017. He is a previous smoker but stopped in 2018 and an occasional alcoholic beverage drinker. He was seen by our service comatose, intubated, and in active convulsions. He was then normotensive with a heart rate of 82 to 97 beats per minute, febrile, and with oxygen saturation of 98% while on mechanical ventilation. Bloody secretions were seen per endotracheal tube. Auscultation was not done then, and the rest of the systemic exam was unremarkable. As for his neurologic status, his eyes were seen partially tonically open, with pupils both non-reactive to light. There was no visual threat and very limited dulls and no corneals. Previously seen intermittent jerks were now seen as continuous myoclonic jerks of both upper, more than the lower extremities, and of the facial muscles, despite additional boluses of diazepam given. Here are representative cuts of his cranial CT showing no evidence of any acute intracranial hemorrhage or major vascular territory infarct. And on review of workup, he had an elevated WBC and glucose, increasing trends of transaminases, and worsening renal function. His ferritin, D-dimer, and high-sensitivity C-reactive protein were all elevated. Although the initial ECG was normal, troponin I came back elevated, and the focus examination showed multi-segmental wall motion abnormality. He was then managed as a case of myoclonic convulsive status epilepticus symptomatic from a hypoxia or anoxia under the neurology service. And under the IM service, he was managed as COVID-19 pneumonia confirmed severe. A loading dose of levetiracetam was given already at the 6th hour of seizures. This resulted in a decrease in the amplitude but not in the frequency of the myoclonic jerks. With IV valproic acid then unavailable at our institution, valproic syrup was started and the patient was hooked to midazolam drip at 0.2 mg per kilogram per minute by the 7th hour. This resulted in lysis of the myoclonic jerks. However, this had to be discontinued after 2 hours because of an episode of hypotension. Valproic acid was likewise put on hold when transaminitis was noted, and he was maintained on a renally adjusted dose of levetiracetam at 500 milligrams tab once daily. No recurrence of seizures has been observed since. He improved initially medically but with no significant improvement in sensorium. But on the 13th hospital day, he had recurrence of tachypnea, desaturation, and hypotension. This was managed as a worsening ventilator-associated pneumonia. And on the 16th hospital day, he succumbed to acute respiratory failure from COVID pneumonia and ends the ACS. That would end my presentation for this patient. Thank you.
Okay, thank you very much, Doc Athena, for that very good presentation. I think the audience probably has a lot of questions about whether or not the seizures are caused by COVID or hypoxia. But let's give that to our discussant. I'd like to introduce our discussant, Dr. Marc Fernandez, who is Associate Clinical Professor at the UP College of Medicine and the Philippine General Hospital. Dr. Marc, welcome to the webinar, and we are glad that you have electricity where you are right now.
Thank you so much, Dr. Susie, and thank you so much, Dr. Raymond, for having me this afternoon. I'm very thankful also that power and electricity and the internet has come back to our town here in San Mateo. So I'm very happy to join you and everyone to present our case today.
Thank you very much, Dr. Marc. So go ahead and make your presentation.
Maraming salamat po. Good afternoon, everyone. I'm Dr. Marc Fernandez, and we're going to present a case and the discussion of COVID-19 being presented with neurologic symptoms. In this lecture, we are going to talk about the neurological complications of COVID-19, and in some parts, we are going to talk about the neuropathological aspects and the therapeutics of these kinds of condition. Next slide, please. So I would like to give us a situationer on the patients that we have seen in the Department of Neurosciences during the period of pandemic from March to July. We haven't added up the other figures coming in from July to the present period, but in the neurology service, there are around 98 patients with COVID that were referred to our service, and around 50% or 49 patients out of the 98 patients referred to us have encephalopathy. If we say encephalopathy, these are conditions that are these are dysfunctions in the central nervous system that are brought about by a dysfunction of the other organs of the body. So there might be a multi-organ failure or a multi-organ damage that can also affect the brain functions as well. We also saw some patients having acute symptomatic seizures. So when we say acute symptomatic seizures, these are seizures that are related to a metabolic derangement that occurred in the body as an effect of an organ dysfunction or an organ damage. So this accounted for around 4.1% of the neuro-COVID cases that we have seen. And for status epilepticus, if we say status epilepticus, these are seizures that are very difficult to control. So there are operational definitions for status epilepticus, wherein if the convulsive seizures or the seizures would not stop for more than 5 minutes and would have no improvement in their mental status or in their sensorium, then we can say that this is status epilepticus. This accounted for around 3.1% of the cases that we have seen from the months of March to July. Next slide, please. So we are going to show also the number of electroencephalograms that we have performed from the months of March to July. So it is also important that we perform these ancillary tests in order to aid us in seeing whether a patient would have continuous seizures or not. So usually in a month, in the pre-pandemic period, we do up to around 100 to 150 EEGs per month. That would include the pediatric and the adult EEGs. However, because of the lockdown, because of the limitations that was brought about by the ECQ, there is a significant drop in the number of procedures that we were able to perform. Similarly, when it comes to the inpatient EEGs, these are also decreased in number because of first of all, the limitations that are brought about. For example, if you are going to do an EEG with a COVID positive patient, then it would entail another machine that you would use that is different or separate from the ones that you're using from a non-COVID patient. So those are some of the limitations that we encountered. Next slide, please. So these are some of the difficulties that we've met during this period. For example, the limited EEG capacity and the decreased census. It is because of the limitations brought about by the ECQ and the pandemic itself. Limited manpower. Similarly, the EEG procedures are mostly reserved for inpatients. It is quite difficult to perform EEGs coming from the outpatient because they are quite wary in going to the hospitals, especially in the COVID centers. So it has also decreased in number, the OPD EEGs. And in terms of the inpatients that are being referred to the neurology service, the referrals that we receive are mostly with poor neurological outcomes, which are brought about by the multifactorial causes. So I think this is mirrored in the presentation that was given by Dr. Athena, that some of our patients would have would arrive at the emergency room with very dire situations because of the overwhelming medical problems that they have at the time of their admission. Next slide, please. So as we know, the COVID itself is not exclusively a respiratory problem, but it can affect different organs of the body. In particular, or for example, in the central nervous system and in the peripheral nervous system. So when we say that there is a confirmed SARS-CoV-2 affecting the central nervous system. So it is important that we check or we detect this SARS-CoV-2 material in the cerebrospinal fluid, in the brain tissue, or any evidence of SARS-CoV antibody that was gathered from the cerebrospinal fluid. On the other hand, we can say that there is a probable SARS-CoV-2 infection if SARS-CoV is detected in the respiratory or in non-CNS sample or in a serum antibody that indicates an acute infection. What sets apart from the confirmed is that the specimen is gathered from either a CSF material, from the cerebrospinal material, or from a tissue of the central nervous system. Next slide, please. So there are different modes, or there are different mechanisms of invasion. So it is quite similar to the different coronaviruses that were explained or that were elucidated in the past. I think this was also seen in the earlier SARS pandemic in 2005, wherein it was also seen to be affecting the central nervous system. There are, I think, 7 coronaviruses, and the last coronavirus was the COVID-19, and it has similar characteristics to the earlier coronaviruses. So coronaviruses, or COVID-19 in particular, would attack cells in the body that have ACE2 receptors, or the angiotensin uh, ACE2 receptors that are expressed in the membranes of the cells. And the ACE2 receptors are found in the brain parenchyma, in the lung parenchyma, in the kidneys, and in the other parts, for example, in the endothelium. So next slide, please. And there are growing data. Can we show the next slide? There are growing data also showing possible mechanisms on how the infection can spread to the central nervous system. For example, in this diagram, we see that in the first part of the diagram here, that for example, the virus is inhaled or entered the nostrils and would attack the olfactory bulb, which is separated from the nasal system through through the cribriform plate. And there are different models done in mice and in other animal studies, showing that these virus particles can be detected in the olfactory bulb within 24 to 48 hours from the time of inhalation. And upon the entry of the virus particles in the central nervous system, it would attach to the different nerve cells the different neurons, and it would traverse different neurons using proteins like dynein or the kinesin proteins until it reaches different parts of the brain, in particular the frontal lobe and the temporal lobe and even the brainstem. So if there are different models also showing that if the virus attacks the brainstem, as we know, the brainstem is a neuroanatomic substrate for respiratory and cardiac control. So for some patients who would have an otherwise unremarkable radiographic features of the respiratory system, but had an acute respiratory failure, then it is a possibility that there are some viral invasion found in the brainstem of the patient. So it would take around 7 days uh, in order for these viral particles to reach the cerebrospinal fluid. So in some cases, there are different literature showing the expression of the virus particles, of the antibodies against the COVID-19 in the CSF. But this can be expressed after quite some time that the patient has been having an infection. So next slide, please. So as mentioned, after the invasion of the virus particles, there comes the concept of neurotropism. So when we say neurotropism, this is the capacity of the virus to replicate or to live inside a tissue, or for example, the brain tissue in this matter. In the earlier studies that were done during the SARS pandemic in 2005, um, SARS-CoV sequences or the genomic materials were also detected in the brain using in their autopsy findings using light microscopy or electron microscopy or even real-time PCR of these specimens. We can show in the next slide that in the in situ hybridization, this detected the genomic sequence of SARS in the cell body and in the cytoplasm material of neurons of patients with SARS. This is quite similar to the COVID-19. We are going to show a recent literature also showing this one. I think this was a study from Italy, a country that was also hardly affected by the COVID-19 infection during the springtime and are having another resurgence as of the moment. So this study has also demonstrated in the autopsy findings when you do electron microscopy of a brain tissue of this patient who died from a COVID-19 infection, and there is an evidence indicating the neuroinvasive properties of the virus. So they were able to isolate particles or features. For example, in the frontal lobe sections, they were able to see the presence of viral particles. They were also able to demonstrate these viral particles in the endothelial cells. So there is a possible dissemination through the hematogenous route in this manner. And neural cell bodies exhibited distended vacuoles and the viral particles itself. So can we show the next slide, please? And I think in the next slide, I think this is quite a difficult photograph to analyze, but showing here in the arrow, in the encircled figures here, that they were able to isolate uh, the viral particles in the brain capillary endothelial cells. So it is possible that we are able to. It may be possible that the viral particles can be isolated in patients with who died from a neuro-COVID infection. Also, next slide, please. So after showing that the virus can invade the central nervous system through a concept of neuroinvasion. The virus can be able to propagate and replicate in the central nervous system through the process of neurotropism. Uh, there is also a concept of neurotoxicity wherein these forms of inflammatory reactions can overwhelm the entire immune system of the body, and there are conditions known as cytokine storms. So cytokines are substances that are present in the body and are seen in inflammatory states. And if we have an increase in the expression of the cytokines, there are cytokine storms that happen, and this can create destructive inflammatory responses that can also bring about, for example, the seizures. In this manner, uh, there is a neurotransmitter called glutamate, and glutamate is a neuroexcitatory substance. And if there is elevated concentration of glutamate in the brain, then this is a situation, for example, an increase in the levels of CNS glutamate. These are situations that are very prone to develop seizures in this manner. So next slide, please. So we have talked about uh, the ability of the virus to invade the central nervous system, the ability of the virus to hijack or to propagate in the central nervous system, bringing in more virus particles and propagating in the brain through the concept of neurotropism and neurotoxicity, wherein if you have these viral particles, if you have this infection brought about by the virus, then the immune system would take its action. However, there are overwhelming immune responses. For example, the cytokine storms that can bring about these kinds of problems. And there are different literature coming from the different countries. For example, in China, the first country that was able to experience the COVID-19 infection, um, seizures itself as the first presentation of COVID-19 is very rare, around 0.5% only. So in a cohort of patients of around 214 patients with COVID-19, only one patient or 0.5 percent presented as seizures as the first presentation of COVID-19. However, the presentation of seizures in a patient with COVID-19 does not necessarily say that that the seizures are brought about by COVID itself, but is an effect of an overwhelming systemic problem. For example, a multi-organ problem or a multi-organ failure brought about by COVID-19 infection. So these are the patients that are brought to the emergency room having very septic, very hypoxic. Their oxygen levels are very low. There are anoxic brain damages brought about by this, and these anoxic brain insults can bring about damages in the cortex of the brain that can bring about repetitive seizures. Seizures in itself, as the primary presentation of COVID-19, is quite rare, about 0.5%, and is likely to be an effect of hypoxia, or a decrease in the oxygen levels, encephalitis, or a structural lesion, for example, stroke, that is secondary to COVID-19 infection. So it is also possible to have strokes from COVID-19. It is because of what we call, or what they call, the prothrombotic state, where it is possible that these patients can have thrombosis because of the infection also. So next slide, please. So we have noted here that in this study that only 0.5% of the patients presented with seizures in this study. For next slide, please. So there is another study coming in from Iran. This is a female who does not have epilepsy but presented with first onset seizures. There are tests that were performed in these patients. They did an MRI, which was unremarkable, the CSF or the cerebrospinal fluid, which showed otherwise an unremarkable status. They did PCR in this patient, a nasopharyngeal swab PCR, which tested positive for the RNA, and they also did CSF RT-PCR, which however tested negative. So it is still possible that these patients would have other systemic problems which are causing the seizures itself. So next slide, please. I think this patient also had an improvement of her seizure status as soon as her COVID-19 infection was treated. Similarly, there is another study coming in from Japan. This patient had a swab, a nasal swab that was negative, but the CSF tested positive. So this is quite worry because it is initially the virus would pass through the nasal area first before reaching the brain. But I think this is still a study that was being uh, elucidated or looked upon if whether a repeat nasal swab was performed in this patient. But it is possible that patients having COVID infection can have encephalitic processes. When we say encephalitis, these are behavioral changes. These are seizures that emanate from the inflammation of the meninges or the lining of the brain brought about by the infection itself. So next slide, please. So there are other studies from the United States showing seizures as the presentation, which happened after a period of dyspnea and altered mental status. However, these are the patients that are brought to the hospital very septic, very anoxic, and died afterwards. There is another child who was brought to the emergency room, however, was discharged the following day as soon as the seizures licensed. So next slide, please. So status epilepticus is, as mentioned, seizures that were very difficult to control, and it would take more than 5 minutes for them to continue in order to say that this is status epilepticus. This is a study from Italy. An elderly lady who had seizures in the past because of a pre-existing seizures brought about by viral encephalitis 2 years ago. So the patient, however, lives in a multi-generational home, which is similar to us here in the Philippines. We have an elderly relative, we have children, we have young adults who all live and eat together and do their family thing together. So this patient acquired the COVID infection from three other relatives who live in the house who are of I think in their 30s. So next slide, please. So this patient actually presented with focal myoclonus. So these are twitching in the face and the limbs. So as you may see in this in the EEG of the patient, this is if you look at the EEG, these are brain activity that were obtained during the EEG process. So you can see this is the right part and this is the left part. And at the right part, you see these motion artifacts that are brought about by these are more motion artifacts that are brought about by the recurrent twitching in the face. And this part on the left is the area where the seizures are emanating from. So, for example, you have the focus of the lesion on the left side of the brain. So the presentation, the outside presentation, the phenotypic presentation would be on the other side of the face. So other side of the body. So in this case, the patient was having seizures on the right side of her body. Fortunately enough, this patient had an improvement of her seizures as soon as the antivirals and the anti-seizure medications were instituted. So next slide, please. So they were able to describe the first case of status epilepticus, and this occurred in the context of a well-controlled post-encephalitic encephalopathy in the absence of pulmonary symptoms. So next slide, please. So we are also going to talk about encephalopathy. If we say encephalopathy, these are dysfunctions in the central nervous system that are brought about by an organ dysfunction in the other parts of the body. For example, a hepatic failure, a renal failure, sepsis, anoxia. These are, should we say, different factors that can lead to the deterioration of brain activity. So, as our professors would also say, multifactorial, para siyang chapsuy, ano, iba-iba yung pinagmumulan, pwedeng from the infection, pwedeng from the organ damage. When we put it all together, then this can bring about the concept of encephalopathy. So first, there is hypoxia. There is a decrease in the blood pressure that is brought about by sepsis. There is the cytokine storm, and all of this can lead to encephalopathy, which is also a neurologic complication of COVID-19 and the other multi-organ problems that are brought about by COVID-19 itself. So next slide, please. I think we are going to show some slides. This is a female. I think this is a study from the United States, an elderly female with altered mental status and seizure-like activity at home. The EEG did not say any seizure activity. Probably these were liaised with the institution of the anti-seizure medications, and the CSF tested negative for SARS-CoV-2. So it is likely that the seizures and the altered mental status are brought about by an organ damage that is also caused by COVID-19 itself. So next slide, please. So they used inflammatory markers. So actually, you would see these patients in the orange. I think these are orange bars. These are the patient. This is the levels of the inflammatory markers that were seen in the patients with COVID-19. They are quite elevated in a way compared to the control or the persons who does not have a COVID-19 infection. So next slide, please. So there is another entity called acute hemorrhagic necrotizing encephalopathy. This is a form of viral invasion or a problem that there is a hemorrhage that are brought about by the infection itself. So mostly it would occur in the midline of the brain, and it would extend sideways, and this would be presenting as a decreased sensorium similarly. And we find some patients with COVID-19 having these kinds of problems also. So this is also a study from the US. A 58-year-old female with altered mental status presented with fever and cough, then decreased mental status. Then when we do imaging, there are infarcts, sometimes hemorrhages that would happen. So next slide, please. I think we are nearing the end of the slides. Also, I think these are the hemorrhages that we see in acute necrotizing encephalopathy that is also brought about possibly by COVID-19. So there are next slide, please. So there are uh, different medications. This is a diagram. This is a table showing the different anti-seizure medications and their interactions with the different experimental anti-viral medications that are being used for COVID-19. And usually there are the newer anti-seizure medications that would have less interaction with the antiviral medications that we have. So it is important that we institute the anti-seizure medications if we are suspecting of a patient having seizures, either whether this is directly related to COVID-19 or an effect of a systemic organ problem brought about by COVID-19 itself. So I think this the next slide, please. We would summarize the our our problem. So how do we tackle with these issues? I think for the outpatient, we do the telemedicine. So we reach out to our patients through the telemedicine in order for them to have a continuity of care and make sure that they are having their issues uh, brought up and treated. There are rotating consultant schedules for the epilepsy service, so we take turns in seeing these patients. First, I think we are doing the EEGs for the non-COVID. Then, afterwards, if we have instituted a protocol for the COVID or we have procured another EEG for the COVID patients, then we can perform more EEGs for them, and EEG cleaning and isolation. It's very important. So I think to summarize, next slide please. COVID-19 can present with extrapulmonary manifestations. For example, this is a patient who presented with seizures, and this can be presenting as neurologic. Seizures, the first seizures being the first presentation of COVID-19 are quite rare, and it can be seen in very severe conditions in the background of COVID-19. And encephalopathy is possibly an effect of cytokine and neuroinflammatory storms. So with that, I would like to show this slide. I would like to thank everyone. I would like to credits to the owner of this picture. We take a great pleasure and thanks to the people who give hope and the care for the patients with COVID-19. Maraming salamat po sa pakikinig, and I hope we have shared some information in this rapidly moving science of COVID-19 and in the neurology. Maraming salamat po.
Thank you very much, Dr. Marc Fernandez. What a brilliant presentation. I kept on taking pictures of your slides.
Maraming salamat po, Dr. Susie.
Yeah, Raymond, I thought we could deviate a little bit from our format because our next two reactors are going to talk about the health system. So I think let's call in the whole panel so we can discuss the case a little bit before we talk about the systems issues. So let's have Athena, Raymond, Dr. Ted, Dr. Marc, and Dr. Bernadette. And I think I see Dean Charlotte Chong. Are you here, Charlotte?
No video for me.
Oh, no video. Okay, so
Okay.
let's have everyone on the panel first and talk about the case. And then after that, we're going to talk about this delay in the treatment of the patient. So I think I'll start off, Raymond, and then please feel free to jump in. No? But I want to ask this question because, you know, when we started this webinar series, COVID was a respiratory illness. We had pulmonologists on the webinar. And then within a few weeks, we had nephrologists because we were seeing renal issues, we saw cardiovascular problems. And same culprit, the ACE2 receptor. But it's only, and then we talked about thromboembolic phenomena. And again, that's all kind of very logical because it's related to the blood system or the circulatory system. But I think now what you're saying, Dr. Marc, is that the virus crosses the blood-brain barrier. And you have given us examples of SARS-CoV-2 in CSF.
Yes, Dr. Susie. It is possible through the process of a neuroinvasion that it can disseminate in different pathways. For example, the first, as mentioned, yung through the nasal system. It can be through a direct invasion, and the other one is hematogenous. For example, these patients would have an overwhelming viral infection. So initially, pwedeng nag-present sila with a respiratory problem. There is an overwhelming viremia, and this virus has crosses the blood-brain barrier. causing the hematogenous invasion. So I think po, Doc Susie, there are different ways on how these viruses can reach the central nervous system. And I definitely agree that COVID-19 is not exclusively a respiratory problem, but a mostly systemic, a systemic illness in itself.
Yeah, and I think the question is, and I think we've seen some of this, and Raymond, you can jump in because we were talking about this last 2 weeks ago, right? That there could be neurological sequelae, which is after the infection. So I think question is, so in this particular case, our patient died, okay? But could the patient develop COVID-19, get well, but have that virus hiding somewhere in your neurological, in your nervous system?
That is a very interesting question din po, Dr. Susie. The science is still evolving. We're not sure if the viruses would have a latent period just like the other viruses that can stay in the brain for a long time after initial treatment are instituted. But there are literature also showing the long COVID problems. They present with different neurologic problems. For example, those who had a stroke before can have seizures afterwards because of the scar tissue brought about by the stroke. But I think po, Doc Susie, this science is really fastly evolving. I haven't seen much literature yet whether how long these viruses can stay in the system for a long time. But we're seeing some patients though that they have some form of some depression, anxiety afterwards, after their infection also.
Yeah. Ted or Charlotte, would you like to add to our discussion? Or Raymond?
Well, actually, there have been reports of long haulers, meaning to say people who get COVID and even after several months, they can complain of brain fog, some form of irritability, some form of weakness, which is waning, so in remission. So I suppose that still there are still some questionable um, sequelae of COVID that we need to understand more. So perhaps it could be due to hypoxia or some changes in the brain. But I suppose that we will have to contend with that and we try to understand more. So the science will still have to evolve and we need to look at those sequelae.
Yeah. Ted, did you want to ask or add to that, to add to the topic?
Yeah, that's true. There's so much still uncertain, and also because the neurologic presentations as presented by Mark are actually of low incidence. So it really will take time before we know about all of this. But the point is, from the health system's perspective and from the emergency medicine perspective side, these rare events are the ones that the system will fail because the physician can miss them. The system can have a protocol but will not cover these cases, and we saw it, I think, in this particular case.
Yeah, Raymond.
So last night, Dr. Mark and I were discussing about a patient that I was very, very similar po to this patient, but had the benefit of a lumbar tap. I was going to ask Dr. Mark if this patient had the benefit of a lumbar tap, what would have been expected results for that lumbar tap of this patient? And then another follow-up question would be, because of the, shall we say, atypical presentation po, no, of COVID-19, specifically for neurological manifestations, should COVID really be something that's near the top of the differentials for these patients, or something that you just think about once you have exhausted everything? Dr. Mark.
Thank you, Dr. Raymond. We talked about this last night about different scenarios involving patients with neurological problems. For example, if a person who presented with acute behavioral changes, seizures, and there was a lumbar tap, usually, as we have mentioned, the neurological complications as first manifestation of COVID-19 are very rare. I also asked the other authors of this literature that we've mentioned. They concur that it's really 1% for China. Even for Italy, it was only 0.5 to 1%. So sometimes, in the confusion brought about by the pandemic, we sometimes might think that these diseases can be because of the COVID or not. So for this case, if this particular patient was stable enough to had a lumbar tap, uh, I am expecting that it is possible that it might have a normal CSF, or it might express the RT-PCR positive for COVID-19. It would be either of the two. If the clinical presentation is so severe, coming from a very overwhelming viremia, then it is possible that CSF can also express antibodies or the viral particles itself. It is also possible, though, that the seizures and the altered mental state are brought about by the systemic damage brought about by COVID-19 in the different parts of the body. So kumbaga, parang nadamay lang yung utak dahil sa pagkasira ng ibang bahagi ng katawan natin. Um, for example, in a patient who has, for a young patient, halimbawa 15 years old, nag-altered mental status, nagkaroon ng seizure. So, top of the mind viral enceph yung maiisip natin. Although viral encephalitis with COVID-19 is quite rare, minsan kasi during the confusion of this pandemic, may isip natin siya na baka siya yun. Although it's quite rare to find this patient. So, um, uh, in these patients, you can also see parang flip of the coin pa rin, pwedeng nag-positive din siya sa COVID or not. Pero minsan nakakaligtaan na rin po natin na may mga iba pa tayong mga tropical diseases that can also cause this, not exclusively from the COVID-19 itself.
I have a question for Athena, because you mentioned earlier that you got called when the patient had seizures in the ICU. Is there a point, and this is for Mark also, is there a point where you call neurology earlier? I don't know. No, I'm not sure about how or why. So it's like there's a stroke, but there's an infection, right? And so and I think this is what Raymond was pointing out, right? Is it going to be top of mind that if you have neurological symptoms, then you think it's related to the COVID, or is this because it took too long for this patient to actually get medical help? So Athena, do you think if at the first knock on the door of an ER, this patient was accepted, that the outcome would have been different?
Oh. It would be really difficult to answer that actually, but I think the patient, it is due to the hypoxia or the lack of oxygen in the brain that the patient had seizures. That is a very classic etiology for the kind of status epilepticus that our patient had. The patient had a myoclonic status epilepticus, and that's actually the most common etiology of that kind of seizures or status epilepticus. So I think it is the prolonged lack of oxygen. So the lack of treatment for that long, I think the patient actually needed intubation for almost 24 hours during the time that they were looking for a hospital that would be able to cater to them. The patient might have done better, although I'm not sure if he would also have worsened in any hospital that he would have been accepted in, because the COVID was actually severe. But the occurrence of the seizures might have been prevented if the patient had been given appropriate care earlier.
Okay, so I think that Raymond, that seems to be a good segue to bring in that, right? We're going to call on that Velasco, who is the operations manager of the One Hospital Command of the Department of Health, because Athena is saying that, if this patient was intubated earlier or given oxygen earlier, I remember in the early days of this webinar, we were talking about just how important it was to have oxygen. Then it seems that um, the problem with the management was that treatment was delayed, or good management was delayed. This person was deprived of the ability to be seen and managed properly. So we're going to call on Det. So are you there, Det? Det Velasco is
Good
the
afternoon.
hi, Det. So you're operations manager for One Hospital Command, and apparently this is some kind of a solution for us so that this doesn't happen again. We've seen on this webinar series so many patients whose care has been delayed because patients are turned down. So maybe you can go ahead and make your presentation then.
Okay.
For
Thank you
for
very
those
much.
Thank you, Dr. Det Velasco. And for those who are wondering why Dr. Det Velasco is here, Undersecretary Vega was called po by Secretary of Health Duque and Secretary Roque to do the rounds as a result of the Typhoon Ulysses that and the effects of it, and we just wanted to, and they all wanted to try and see what are the needs on the ground po. So we are very lucky to have Dr. Det Velasco to present Undersecretary Vega's presentation, and Dr. Velasquez also, I believe, an emergency medicine specialist po. Dr. Det.
Yeah, good afternoon po to everyone. Yusek Bong Vega would like to send his sincerest apology for not making it in this webinar series. Because, yeah, as mentioned by Dr. Raymond, is doing his rounds around NCR and also in 4A to check the status of the hospitals in or the healthcare facilities in that areas. So I'm here to discuss one aspect of the government's program to fight the pandemic COVID-19. So this is the One Hospital Command Center. It's actually part of the COVID-19 response. As you know, we have the T3 program of the national government, which is test, trace, and treat. So in test, we have the aggressive community testing. In trace, we have the contact tracing headed by Mayor Magalong of Baguio. And then for the treat part, we have the hospitals and the Oplan Kalinga, which are all the healthcare facilities um, that being handled by the national government. So the Department of Health, as the nation's leader to health, is committed in guaranteeing equitable, accessible, and quality health services to Filipinos at all times. That's why this One Hospital Command Centers was conceptualized. Um, Now, this is a simple structure of what the COVID-19 Command Center is. We follow the IATF and the NTF guidelines inside the COVID-19 Command Center. Among the people handling the COVID-19 Command Center are the following agencies, which are MMDA and DOH, Department of Health. We also have NTF, BCDA, and also DOT. So MMDA, BCDA, and DOT, they are the ones handling the national government operated Oplan Kalinga or the TTMF, temporary treatment monitoring facilities. These are the hotels and the mega quarantine facilities. They also monitor the local government operated quarantine facilities or isolation facilities. For the Department of Health, we also monitor the quarantine facilities, isolation facilities, but most especially the hospitals, be it a private hospital or a DOH retained hospital or an LGU hospital. As you can see here in the org structure, we have an attached call center agent, which is Pure Force. This is the system that we are using under the One Hospital Command. So they donated their system in the Department of Health to use during the COVID-19 response. Um, so the reason why we get a call center agent or for agent to gather information is that we're expecting a lot of calls coming from the community or from the healthcare facility. So they triage the patient. If it's stable, they just gather all the information necessary for that case, and then through the system, they transfer the gathered information in the one hospital command center. Now, as mentioned, we also handle the Oplan Kalinga. We act as the medical director of the Oplan Kalinga. Anything about medical issues or concern, they course it through the one hospital command center, as well as aggressive community testing and contact tracing. So inside this COVID-19 command center, we communicate directly with each other, each program of the national government, so that it's easier to facilitate and to communicate with one another just to solve the issues or concern of the caller. So this is the objective of the unified response to COVID-19. So we want to establish a one hospital command to optimize use of critical care services in hospital. And we also want to strengthen the health system capacity of each healthcare facility. So we have this Department Order 2020-0653, which is the guidelines on the creation of the one hospital command system. This is to establish and facilitate coordination between health facilities and healthcare provider network, as well as to streamline the referral and transfer of COVID-19 cases. As mentioned, we don't want the cases to be hopping or doing hospital hopping just to see where they can be admitted or they can be assessed. And then also this one hospital command system shall serve as the interim national referral system as mandated by Section 7 of the Republic Act 11494, which is the Bayanihan to Recover Act as one, and shall subsist despite the expiration of the said act. So we are expecting this one hospital command center will still be operationalized even after the COVID-19 pandemic. Also seen here in the slide, we have the main services of the COVID-19 of the One Hospital Command Center, which is data analytics, medical dispatch, the call center, and the medical transport, and then the coordination. The main function of this data analytics shall be responsible for data gathering and analyzing as needed by the operations managers in the One Hospital Command Center for planning, policy making, and also monitoring the healthcare facilities. For the call center and medical transport, this will be responsible to all communicated received through the One Hospital Command Center and facilitate medical transport and dispatch requests by the hospital or even coming from the community. For the coordination and communication team, they are the ones handling the risk communication messages and health communications that being handled by the One Hospital Command Center. So this slide will show you how the One Hospital Command Center operates. So anyone can call the One Hospital Command Center. So we have one landline, we have one smart line and one globe line, as well as we have the Pure for Citizen app that can be downloadable in both iOS and Android for free. So once you communicated with the One Hospital Command Center, this will be answered by an offsite center, which is Pure Force. Then we are operating 24/7. So if the queries or the concern is just frequently asked question, they'll be the one answering it. Like for example, swabbing, reporting, quarantine, or just simple consultation, they'll be the one answering it. However, if it is um, if there are patient referral, so through the PureFirst system, they will endorse it to us in the command center, and then we review the case, and then the coordinators will look for the appropriate bed through the DOH bed tracker, and then also with the Oplan Kalinga bed tracker. So once we identify an available bed, we coordinate with that facility or agency concerned so that we can officially coordinate or refer that patient so that they'll be accepted. So once with the acceptance, we give feedback to the caller again, and then if there are um, medical transport requests, we also coordinate with the EMS team or the pre-hospital provider team, be it coming from the volunteer group, the LGUs, or private pre-hospital providers. As you can see, these operations are actually based on the WHO Emergency Care System framework, wherein there are three sites. So the first site would be the scene, which is the community and then dispatcher. So that entails the off-site call center and then the community. And then we also have transport, which is the medical transport. So we coordinate also with the different pre-hospital providers in the country. And then lastly, the facilities wherein we coordinate with the TTMF, hospitals, and other agencies concerned. So again, the scene, transport, and then the facilities. Also in these slides, as you can see, this is the command center, the big photo on your right. So that's the monitors that we have in the COVID-19 command center. We have there the Pure Force system. We also have there the DOH bed tracker, and then the Oplan Kalinga, the hotel isolation facilities, available beds. And then as you can also see here in the slide is a photo or is a snapshot of where the calls are coming from. So this is actually a zoom in photo coming from NCR. So majority of our calls are coming from NCR right now, but as the day passes, we're slowly having a number of calls coming from different regions. Having said that, inside also the department order 2020-0653, we also made the guidelines on the decentralization of the one hospital command center operation. So we wanted to have a regional OHCC counterpart so that the community there or the healthcare provider network there will be and then the referral there will be easier. And given the fact that there are also language barriers and the peculiarities of the different areas in our country, so it's easier for them to decide where to bring the patient in their region. But the National One Hospital Command Center is still there monitoring and ready for support in case that there will be regional to regional interfacility transfer or referrals. Now, what we've been doing is talking to different LGUs and different CHPs in the Department of Health because we wanted the time critical patient to be brought to the nearest appropriate hospital immediately, not necessarily being admitted in that area, but we wanted them to be resuscitated and facilitate immediately um, so that there will be a better outcome for that patient. So once resuscitated and stabilized, if that hospital or healthcare facility will not be able to admit that patient, they can again course through the one hospital command center to facility transfer to another hospital, which is the interfacility transfer. For the urgent and the non-urgent cases, the more stable ones, we look for the proper COVID referral hospitals, or if they request for private hospital, then we coordinate them to the private hospital, or even to the asymptomatic and mild symptomatic patient, we course it through the Oplan Kalinga to look for available beds. So you can see here that for time critical cases, we refer the patient or we coordinate the cases regardless of the COVID status. But for urgent and ambulatory stable, the more stable cases, we coordinate only COVID confirmed cases. However, for suspect or probable cases, we also deal with that inside the one hospital command center. The direction now is that any medical concern can be coursed through the One Hospital Command Center, and we just coordinate them. So we also have a partner, the Health Emergency Management Bureau under the Department of Health. They are the one handling the non-COVID cases. So those with no respiratory symptoms or no COVID symptoms and has a confirmatory test of RT-PCR of negative, they are the one handling it. But if there are a lot of cases being handled by them, so the One Hospital Command Center coordinators also augment in helping them to look for available beds, again, through the DOH bed tracker. Now, this is a simple diagram on how we communicate or the plan of communication inside the One Hospital Command Center. We have the 1555, which is the COVID hotline of the Department of Health. When we started the One Hospital Command Center, medyo konti pa lang yung knowledge namin on 1555. So what we did is when we started operationalizing the OHCC, so we communicated with 1555. So right now, if you call 1555, you can also, your call will be directly rerouted to OHCC if there is a patient referral. Now, we also have a second OHCC call center, which is the Bantay Bata call center. So we're training them how to handle calls inside the OHCC. So if there are overflows inside the first OHCC center, they'll be the one handling it. But again, there's no need of putting down the phone. So it's automatically rerouted to that call center. Now, the plan of the National One Hospital Command Center inside the MMDA is to have, again, a subnational or regional OHCC, as well as direct communication with all the hospitals nationally, and also TTMFs, the temporary treatment monitoring facilities, and also with the pre-hospital providers or the EMS, and also with the contact tracers with the aggressive community testing group, and also with the Oplan Kalinga. Having said that, so this is the OHCC ICT architecture overlay. I'm really having difficulty of of understanding this before, but to make it simple, we have a donor, which is PCSO. Um, they gave us their PABX system to One Hospital Command Center. So what the PCSO PABX system will do is that they'll they'll give us direct communication with the subnational and regional OHCC so that it will be easier for us to communicate with one another. They will also give direct communication with for now, the plan is to have the level 3 hospitals to have direct communication, and also with the Oplan Kalinga and with the ACT and contact tracing group. As far as TTMF concerned, right now we have direct communication with them because the 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 BCDA gave them in an app so that we can communicate directly. So that will be the OHCC ICT architecture overlay. So this one is for Metro Manila. For um, for the nationwide communication, the plan is to have a Cebu branch, which will be the Visayas branch, and also the Davao branch, which will be the Mindanao branch. So that if one will have malfunction, like for example in the national level, we can easily course it through the Cebu or Davao branch and then back to the national. So also the plan for the PCSO nationwide communication, also part of the nationwide communication network of the PABX system in the One Hospital Command Center, is to have the nationwide hospitals so that we have direct communication with the hospitals. And also the PABX system is also capable of having webinars or even video conferences. So this will be my last slide. So just to give you an overview what the One Hospital Command Center has been doing. So right now we have 6,358 cases being handled. And then 6,308 or 99.21% of which are already closed. And then we only have 50 cases being handled right now. So these are the active cases. Majority of these cases are the asymptomatic or mild symptomatic cases are that needs hospital isolation facilities and or even quarantine facilities. This data is as of November 11, 11:59 p.m. So having said all the operations and how we communicate with other healthcare facilities. So we need cooperations inside the hospital. So not only the patient, we also need cooperation inside the hospital so that they'll give the proper information to the one hospital command center. Again, we base our decision on the DOH bed tracker. So if we see that there are available beds, we communicate with them. And then we also need cooperation from the healthcare facilities, like for example, clinics or or even the TTMFs. So we need cooperations with them and even the doctors. So don't let a COVID positive patient go or sue them away because you don't have available beds. You can communicate again with one hospital command center so that we can refer the patient properly in the proper healthcare facility so that we prevent hospital hopping to that patient. And also, we need to communicate with, or we need cooperation coming from the community or from the patient themselves, because we are having difficulty in um, asking the patient to cooperate with us, like we have an available bed in this hospital but sila naman yung ayaw pumunta doon. Okay, and then also of course LGU and the BHERT has a big role in this pandemic. We need their cooperation, and of course the pre-hospital providers as well. With that, I'll end my presentation. Thank you very much for listening.
Thank you very much, Det Velasco, for your time and for that presentation. And I'm sure there are a lot of questions. We're going to ask some of our panelists to come back later to ask. I have a lot of questions. And I've seen some questions in the Q&A box. But we're going to call in Dr. Ted Herbosa now to react to that presentation and to talk a little bit about the system and how the system should be responding to the needs. Because I think that is describing, and one of my questions would be how much of it is a plan and how much of it is actual operational, right? But we'll save that for later. Let's ask Dr. Ted Herbosa to give his view on the system's response so that we don't have people who are unnecessarily dying because they cannot access hospital care. Ted, please go ahead.
Thank you, Susie. Allow me to share my screen first. Oops.
Yeah, go ahead.
Screen. Let me see. So am I sharing my screen already?
Yeah, I can see it.
Let me just go to my presentation. Okay. Thank you, Susie, for that kind introduction. Actually, I looked at the problem, and this problem has bugged me. I had served as 12 years as the chairman of the Department of Emergency Medicine at the Philippine General Hospital. And neurologic cases were dime a dozen and was the main problem in most of our admissions. There was a long backlog of neurologic cases, either from stroke, seizures, or altered mental status. And the problem was an infrastructure gap wherein the neurology ICU was always full. The neurology ward was always full because neuro cases tend to be chronic and stayed longer in the hospital, while the new cases continued to add up. So we defined that in emergency medicine as an access block. And when COVID-19 hit, the access block became bigger because you now have aerosolizing procedures that people didn't want to perform unless they were ready, like intubating a patient with altered sensorium. So we saw the problem in this particular case highlighted and affected the outcome. So I decided to cover this particular topic by looking at the big picture, and I asked all our clinicians to also do so. Let's look at the big picture and study how we can reform our health system with the proper leadership and governance. So we're building a health system now. We passed the universal healthcare law last year, and we've been evolving and trying to improve the health system, which is actually needs a lot of improvement. And everyone needs to have to look at this from a strategic perspective so that policy formulations are done, so that oversight and accountability can actually be seen, especially for cases with bad outcomes, like what we've been done in this virtual grand rounds, and be able to demonstrate actual results. And I come to you with the concept of accountability in the healthcare governance. Accountability, as defined by the WHO, is the intrinsic aspect of governance that concerns the management and relationships of various stakeholders in health, including individuals, households, communities, firms, governments, non governmental organizations, private firms, and other entities that have responsibility to finance, monitor, deliver, and use the health services. I have an anecdote. When I became head of the ER of PGH, I learned that the ER of PGH had another name, and I wanted to build a hospital with that name. It was called HOC. Do you know what HOC means? It's written in all referrals of patients that are brought to PGH to hospital of choice. And that really clarifies that we have a problem in our healthcare system. So it's very important that if you're going to have good governance, we should be able to delegate and understand either implicitly or explicitly how emergency services like this one for this particular case that we're discussing should have been delivered, and who and when it can be improved and uh, corrected. So we also need to understand proper financing and performance of the services that will be needed by a patient like this. All of this were all disrupted during the COVID-19, and enforcement became even more difficult. So I looked at the problem and say the main problem is actually governance in healthcare system, the opposite of corrupted system. A corrupted system fails our patients. So we need to have this governance in health that has a cross-cutting theme that is intimately related to accountability by the health professionals to our patients that we serve, accountability to the universal healthcare system that we espouse. And we need to have a consensus on this. And to be able to get consensus, we need leadership, just like the One Hospital Command Center. A command center actually is an epitome of good leadership and governance. So when you look at the health system, there are indicators in which you can measure the governance of that health system. And theoretically, there are two indicators, what we call the rules-based indicators, which is what is commonly used by us now, and the outcomes-based indicators, which are actually what we should be going to and evolving into. And the rules-based actually measures whether countries have appropriate policies, whether it's present or not. Let me just explain in the next slide. For example, these are examples of rules-based indicators. We have a national essential drugs list. We have a national policy on malaria control, TB control. All these policies are in place. These are rules on how to manage COVID. We have COVID protocols. We have all these things that we put in. So there must be ownership in that. Decentralization, like what the One Hospital Command, we will devolve it to the lower units, to the CHDs and the local governments, and must be able to contextualize the environment. In outcomes based, we look at, for example, if it's a national drugs list, yes, we have a national drug list. But the question you ask in outcomes based is there availability of the essential drugs to the facilities that need them at the time they need them? So that's the other problem. So that's the outcome you want. Are the health workers available? So you may have all the health infrastructure, you're counting hospital beds, number of doctors, number of nurses, but like yesterday, after Typhoon Ulysses hit us in Metro Manila, many hospitals were saying their new fresh of shift of nurses and doctors couldn't even go to the hospital. So that's going to affect outcome at that day. Then the other outcome-based indicators, which are really relate directly to the functioning of the health system, and WHO names this as the building blocks, including what you saw in the empowerment of the One Hospital Command, which is the use of digital technology or information technology or data analytics. Now, the sources of health information in governments, you can use all of them: rules-based, expert analysis, expert views on national policies that we need to discuss, something like a forum like this one in Stop COVID Deaths, administrative records, legal reviews, and most important is now the opportunity to do this using big data and data analytics and artificial intelligence. As you can see, the outcome-based indicators are generated using our data sources. So one of these data sources is actually the PhilHealth, because PhilHealth has a repository of a lot of data of all the patients that were treated in our hospital. We can have facility surveys looking at whether the public is happy the way they have been served there. And the expenditure, what has the government spent for? Has it spent for maternal and child care? Has it spent for trauma care? Has it spent for infectious diseases? Client assessment, that means the people that pass through the ER, the hospital, are assessed and asked if they're happy with the service that the public hospital has given them or the private hospital with them, and put them all in data and put them in the, data science. These are some of the core indicators, and these are just examples that we don't have to go through all of them. And these are some indicators that we can look at to actually uh, understand how the system can be improved. And for emergency care, especially emergency care of, let's say, altered mental status, I think the provision of airway and oxygen is a priority, and any physician will tell you that so. And the fact that this patient waited 24 hours to even get that is actually a big stumbling block to his survival and good outcome. So these are just other examples of indicators we can use. Now, when the theorists and public health people conceptualize the health system, they conceptualize an ideal model wherein the family will consult a health station, and the health station, if they cannot handle them, will refer them to a district hospital, and the district hospital, if they cannot handle them, will refer them to a tertiary referral hospital. Very nice and very efficient. Unfortunately, that's exactly what doesn't happen. And I saw that when I was Undersecretary of Health. The patients really bypass the health center because it's usually the doctor is only there once a week, and it's usually manned by one of their colleagues, which is a housewife volunteer, a barangay health worker. So the patients have little confidence on the health station because the doctors, the primary doctors, aren't there. So they go straight to the district hospital, but sometimes in the district hospital, they're told, we don't have the equipment to handle your case. So eventually they learn, and they never go to these two steps. They go to the government hospital for their referral. Others, because the government hospital, by the time they get there, is also overloaded and overcrowded, and there's access block, like what I told you in PGH. Most neurology cases we will turn away because the ICU beds of neurology were full, or the ward beds of neurology were full. So the poor pay family is forced to go to private hospitals where they spend more and become impoverished some more. So the ideal system is something like this, where we can manage everything in the one hospital command. And I saw a comment about the wish of a attendee saying, we wish the one hospital command would stay even after the COVID crisis. And I agree. I agree that we need a gatekeeper or a system per region, per city, per province, probably. I don't know what system would be, but to be able to maximize the rationing of healthcare resources appropriately. And we need to have both the public and the private sector in that. Lastly, I'd like to talk about the Harvard model of those of you who are audiophiles. You learn about making the nicest sound coming out of your radio or stereo, and you have knobs to actually turn them either bass up or bass or treble down or whatever, and to get the best music that you want to hear. And the healthcare system is something like that. You have the health financing, the first one is your financing model. We have that already because of the Universal Healthcare Law and PhilHealth. The payment system is a big argument. We've been trying to move from fee for service to case payment and hopefully to global payment systems. Then we look at the organization, and this is where the networking and the local health systems, interrelated local health systems, the hub and spokes model needs to be worked out. And lastly is regulation. Regulation is the job of the government, Department of Health, that license hospital, the PRC that licenses the professionals, and FDA that licenses the drugs and supplies that we use. And the last knob, which is really the most difficult, is really behavior. We need to have a literate population. That means educating them with correct information so that they will know how to wade through the system. Now, in the middle column, you will see three intermediate performance indicators. This is actually your efficiency, your quality of healthcare, and your access to that healthcare. And all of this were actually highlighted by the case we presented today. And of course, the last one is really actually what we call the targets or the performance goals, which is really the health status or the health outcome, the satisfaction of the patients, and being able to have risk protection for the whole population. So with that, I'd like to thank you all for the opportunity to address this from a health policy perspective. And in the time of COVID and in the time of this disaster, the recent Ulysses typhoon, we've seen how important it is to work together and heal as one. Thank you very much, Susie and Raymond.
Thank you very much. It's Dr. Ted Herbosa, the Executive Vice President of the University of the Philippines, and really a very, what should I say, very good analysis of what the system should be working toward. Like, saan tayo dapat pumunta, no? And I think sometimes we're in the weeds, we're looking at the little problems. So I guess your earlier appeal for us to all step back and look at the whole system is a very important one. Because, and I kind of heard this a little bit from them, that they need people to collaborate and the hospitals to collaborate and clinicians to collaborate. I guess we all have to be on the same presentation that you need in order for the system to change, because it can't just happen because someone says it's going to happen. I think, and that's where the governance and the leadership part of it comes in. So thank you very much, Ted. I thought that was really very instructive for everybody. Raymond, did you have some? I think you wanted to say something.
Oh no, I was just going to confirm since I believe there might be some technical problems with some of our attendees. That's why they might need to leave. I just want to ask this directly to Dr. Det. Dr. Det, for those who, in terms of contacting the One Hospital Command Center, is there just one number that they should call? And regardless kung ano man po yun, just so if you could repeat that will be very beneficial po. Because you mentioned like a number 1555 or something. So para lang po sa kaalaman ng iba, and do you envision that if it's true that it's just one number, do you envision that one number being retained as one hospital command is replicated in the different regions po?
Yeah, thank you, Dr. Raymond. So 1555 is the COVID-19 hotline. So any concerns about COVID-19, you can course it through 1555. However, we have, I guess, to any emergency, we need redundancy. And when we started, we don't know about 1555, so that we establish our own numbers. So this is 886-50500. So that's our landline number. So that is direct communication with the One Hospital Command Center. And then we also have cellular phones given by the partner agency. So should I mention the number? Okay, 0919-977-3333 and 0915-777-7777. So that's our cellular phone, because some of the community are having problem in communicating or calling the landlines. Pero yung 1555, I guess pwede yun sa mga cellular phones. So if there is one number, you can call 1555 and they will just reroute it to One Hospital Command Center.
Okay,
Yeah.
Thank you so much for that clarification, Dr. Det. I'm sure a lot of our attendees po, especially for those who are very much involved in the administration of the hospital and trying to figure out how to refer these patients, will benefit from that. Thank you so much. Dr. Susie.
Yeah, Raymond, we're close to the hour, and maybe you want to give the answers to the questions on the fun poll first.
Okay, so maybe we could have, there we go. Okay, I'd like to call on, these questions really were nominated by Dr. Athena po. No? I'll read the questions and then I'll call on Dr. Athena to provide the correct answers. For this one, the first question reads, 80-year-old, previously independent in all activities, brought for recurrent generalized tonic-clonic seizures lasting 2 minutes, occurring 10 times in the last 2 hours, and has been unresponsive since the first seizure. This patient should then be managed as status epilepticus. Dr. Athena?
Actually, our participants got it correctly. So this is true. Patients with continuous seizures for 5 minutes or more, and patients with seizures lasting less than 5 minutes but without return to baseline sensorium should be managed as status epilepticus.
Thank you, Dr. Athena. And the next question reads, which among the following is the most commonly associated with myoclonic status epilepticus? The answer is?
So although this was close, they still got it correctly. Anoxic encephalopathy is most commonly associated with myoclonic status epilepticus, and our literature would say that around 60 to 70% of patients presenting with anoxic myoclonic status epilepticus with myoclonic status epilepticus would be of anoxic etiology.
Okay, thank you so much, Dr. Athena, for answering those questions po. No? There's a question, I think maybe we can have 1 or 2 more questions for our public health panel po, Dr. Susie. And then it reads po, maybe this is for EVP Ted, who is a former DOH Undersecretary. What is the PhilHealth and DSWD mechanism for financial assistance of patients who are cash-strapped, especially during this time of the pandemic, and those who were stricken by the typhoon?
Before Ted answers that question, kasi I saw that question, it's from Maria Cecilia Polido, and I think we should also ask that, right? If you call 1555, is everything going to be free, or what is the responsibility of the patient? So I think maybe both of you can answer that. I don't know if Ted wants to answer it.
Yeah, I want to answer that because I think that's where the universal healthcare law really comes into play. We're one of the countries that passed the law, but we've not really implemented it. And what does the law say? The law says that all Filipinos who are citizens of the Philippines are covered under the PhilHealth, under the National Health Insurance Act. The problem is that the right to health care, the right to health is there provided by the Constitution, but the right to health care is assumed based on the system we actually build. So that's going to happen only if the government invests in the health infrastructure and the health human resources. So we'll put them in a government hospital so that they have a no balance billing system, which was implemented during my time and continues to be practiced today. But the no balance billing system is not sustainable. It's got to be analyzed with the cost health economics, proper health economics on what are the common diseases, how much do we reimburse for cases, and there must be a level of copay. I think what will happen in the future is that the level of copay of our citizens is the one that will be determined, and that will change. If you are from the lower socioeconomic sector, I expect that the state will take care of you from whatever sources it can handle, whether it's PhilHealth, PAGCOR, or non-government or religious organization. But if you have a level of economic capability, then you should have a level of copay to be able to actually subsidize the cost of healthcare that is provided for you. And the cost of healthcare is getting more expensive. The government would like to pay for all the COVID cases, but critical care is expensive. The new drugs are expensive. The new vaccines are going to be expensive. So it becomes a problem really of health financing and in short, health rationing. Basically, it's just being able to ration enough for the 110 million Filipinos we have out there. Thank you, Susie.
So we have the rule, but we're not at outcome yet.
We're not at outcomes based. Yeah, we're not yet at outcomes based. True.
Yeah, Dad, did you want to say something about that? When we call 1555, is it going to be free?
Yeah, it's really free. If you call 1555 or one hospital command center, it's free. Even how long we communicate with you, coordinator call, it's free. If the caller or the patient has a choice if they want to be admitted to a private hospital or a government hospital, we usually ask them where do they want to be admitted. What's the preferred hospital? So we coordinate with that hospital. If it's not available, we look for another hospital. But the service of one hospital command center is free. We usually have calls asking for financial help as well. We don't deal with hospital referrals only. We also deal with issues like paano kami magbabayad sa hospital. So the one hospital command center does not give money or financial help to the caller, but we endorse them to the Malasakit Center. As you all know, with the RA 11463, so we have the Malasakit Center in the hospital. So we endorse that case. So we directly communicate with the DOH Central Malasakit Center, and then they endorse the case to the Malasakit Center of the institution or healthcare facility involved, so that they can prioritize the needs of that patient.
So that what are you guys doing to inform everyone that they can call 155?
Right now, we're partnering with the communication team of Department of Health. So as you know, yesterday we just released an e-poster that aside from handling the COVID-19 response, we also help with the Typhoon Ulysses. So we had a lots of call coming from the community, from the typhoon-stricken areas, asking for rescue response. So we do communicate with the director Beverly Ho. So she's the one approving our communication, and every day we release also a note on how they can communicate with us through the One Hospital Command Center. And we also have a group with different hospital directors, so that we can also lay out the plans of the One Hospital Command. And we can also solve issues on the healthcare facilities.
That when I call you from my cell phone, the one hospital, my cell phone company will charge me. So it is not free.
It's for if 1555, I guess I think it's free, sir.
You think it's free or is it?
Yeah.
So
I
even if I dial, even if I don't have load, I can call 1555 and it's free. But for the other numbers you gave, then I have to
It's not.
pay.
Yeah.
Okay. Thank you.
Thank
Okay.
you, EPP Ted. Dr. Det, just one last question po. No? You mentioned earlier that One Hospital Command Center is the most mature in the National Capital Region. So for those, and you notice also that we have attendees all the way from Negros Occidental, from Aklan, from Mindanao, etc. When do you think they should expect the same level of maturity in terms of having their own One Hospital Command for their own regions?
Yeah. So right now, since the release of the department order of establishing the regional OHCC, we're starting to communicate with the regional CHDs of each region. However, it should not be a replication of the One Hospital Command Center. It could be the same function of what One Hospital Command Center is doing here in the national level. There are already established emergency operation center in each regions through the regional IATF or NTF. So basically, it's already there. Main function lang ng One Hospital Command Center should be established or strengthened na lang with the communications through the local government units and through the available healthcare facilities.
Okay, thank you very much, Deb. We'll have to, in the interest of time, I think Raymond do just our quick evaluation, and we're gonna ask everyone to give their parting words, just a few sentences. But Raymond, you want to run the assessment?
Okay, so after every panel discussion, we have this assessment of the panel discussion really in terms, okay, maybe we can have that, there we go. Okay, so in terms of the level of knowledge and that the attendees gain from this webinar. There are 5 components for this assessment. I'll just read off the list. The panelists demonstrated thorough knowledge of the case study. The panelists were well prepared and organized. The panelists spoke clearly and audibly. The panelists used appropriate language with technical medical jargons adequately explained. And finally, contributed to new perspectives and knowledge on managing various key COVID-19 health issues. So for our attendees who are still in this Zoom webinar, 180 plus, please key in your assessments for this particular webinar. And please continue to key them in as we get the final messages from each of our panelists.
Thank you so much. Okay, we're going to start with Athena. What's your parting message to our audience?
Dr. Athena, I think you're on mute. Sorry.
Yeah, I guess I would just like everyone to remember that seizures can be present in many cases, and not just in neurologic cases. That they can be seen even in patients with systemic diseases, including those with COVID-19. And it is continuous seizures, such as what we saw in our patient, is an emergency, a neurologic emergency, and it is important to attend to these cases or conditions appropriately.
Thank you very much. Mark.
Thank you so much for having me also. Just like the brain that works harmoniously with network systems, I think the harmonization of the healthcare network systems are very important in order for us to have a very good delivery of healthcare. And we know also that for time is brain, every minute lost are neurons also inevitably lost. So maraming salamat din po at ingat po tayong lahat.
Thank you, Mark. Deb.
Yeah, thank you for inviting us in this webinar. Again, 2020 is all about COVID-19 pandemic. We discovered a lot of things. We discovered what we are strong at. We discovered what the healthcare system is lacking. So as the Republic Act 1149 says, so we really need to recover as one. It's not to just one agency, but around the country, nationwide, and all agencies should recover as one. Thank you.
Thank you, Ted.
Well, I think I'll talk about solidarity, the importance in being able to combine both the public and the private sector, and announce that I'm currently working with the team of Senator Angara to be able to develop a Apex hospital or a PGH in every province or every region, whatever is possible, to really implement the universal healthcare and the network and the local area network, because you cannot just build primary care. With the primary care, you need to build also a lead system or a lead hospital where patients go, so that patients like this will not be shopping and they're all connected and there will be efficiency and the services will be having good outcomes, as Susie said. Thank you very much, Susie.
Thank you. I think Dean Charlotte is still here. Charlotte, you want to give a few words?
Well, thanks, Susie. No, I'm sorry I don't have a video because of connectivity issues. But I'd like to thank you again for hosting this. The College of Medicine is really invested in this. That's why we have these virtual grand rounds. We're getting better at it. I'm very happy that the different departments have been able to accumulate so much experience in how we deal with COVID. And now we're talking about the health systems approach, which to us is very important as well. I just had a meeting with the interns. Most of them will be coming back, hopefully, by the end of this November. We've been allowed by IATF to bring back the interns. Hopefully, we'll give a good model by which other hospitals might follow suit. So thanks again, and keep safe, everyone.
Thank you. Okay, so we've got closing remarks by Chancellor Menchit Padilla, who's with us and who was listening very carefully. Menchit, go ahead.
Okay, so well, it's been a good 2 hours again. So we started with UP Executive Vice President Ted Herbosa, who gave the background of the creation of the stub COVID deaths. He has been instrumental in setting it up, and he said that this is the new normal. This is the educational webinar series, and we're here to stay. We had a very interesting case presented by Dr. Athena Antonio, a 90-year-old male, just presenting with fever and difficulty of breathing at the beginning, admitted to the hospital, but there was great difficulty moving to a next hospital, and during the wait, there was a progression of the symptoms such that eventually the patient had severe COVID pneumonia and of course status epilepticus. From Dr. Marc Fernandez, these are the lessons that I picked up. One, he said, COVID-19 can present with extrapulmonary manifestations, but the seizure is a rare first occurrence. And as a matter of fact, it really starts somewhere, and he gave us the mechanism on how it goes to the brain. And this is what I picked up from him, that the mechanism is that it starts in one place and then it goes to the brain. It cuts across the brain barrier, that's neuroinvasion. Once it gets to the brain, you have the neurotropism, wherein the virus actually propagates and multiplies. And then eventually you have the neurotoxicity. So when you talk about a patient, a COVID-19 patient presenting now with seizures, you really are looking at the brain being affected because probably of the multi-organ failure. And that's why he said that it's very important to actually treat them immediately, because that way can actually affect the brain. And as he said, every minute is important for the brain. I'm happy to note that they've come up with COVID measures, and I hope everybody remembers this. You know, in response to the patients and the delay of transport to the hospital, they said that they've implemented telemedicine for OPD epilepsy. They've decided to have a rotating consultant schedule for the epilepsy service. And then they've limited the EEGs for non-COVID patients, and they made sure that they cleaned actually the EEG to make sure that it is safe and clean for the next patient. That was the first segment, and the second segment was all about how the Department of Health is responding. And we're very fortunate today that the Department of Health presented their response to a prevailing problems. If you've been our viewer for the past couple of months, we have heard stories of patients moving from one hospital to another until they find a hospital who will accept them. But the answer of the DOH now is the One Hospital Command Center, which actually started in July but became official in August 6. And they've got this motto. They've got test, trace, and treat. And that is aggressive community testing, contact tracing, and getting hospitals engaged in the hospitals of Plan Kalinga. So you have to remember that. There's only one thing probably have to remember as far as the One Command Center is concerned. Remember the number hotline 1555, which is the hotline for COVID-19. And this hotline is going to guide you to the next steps. The day ended really with the presentations ended with Dr. Herbosa talking about the bigger system. And I think, it's nice to end with this, because no matter even if we respond to the problem of COVID without responding to the bigger problem, and that's the system, the governments and health, we will not be able to move forward. I encourage you to actually watch the replay, because he talked about the governance in health. And it's so nice to hear from him that the One Command Center, as a gatekeeper to maximize the rationing of healthcare, probably is a step towards the dream of the Philippines. So the Harvard World Bank flagship with the 5 control knobs is something I think we should go back and visit, do watch the replay. But the important thing now is that for our viewers, this is the message. There is renewed hope for our patients with the One Hospital Command Center, the gatekeeper to private and public hospitals. So just remember, dial 1555. Magandang hapon po sa inyong lahat.
Thank you very much. That's our Chancellor of UP Manila, Menchik Padilla, who always blows us away with her summary. And we'd just like to thank everyone. I think on the results, we saw a strong agree with the assessment of our speakers today. I'd like to thank everyone for that. Next week, okay, next week we have a special topic. And I'm going to have to look at my screen to read it. It's the Virtual International Conference on Medical Education in the Pandemic, Part 2. And this is about innovation and transformation for medical students. I'll repeat. It's on innovation and transformation for medical students. Earlier, I was struck by what EVP Ted said, that this group that's presenting this webinar has never physically met. I mean, I have no idea if Rika is taller than me or not, but we are able to get things done. And so I think for medical education, this is also coming with Dean Charlotte Chong's call for a can-do attitude. You know, we're going to produce doctors even if we are at war and in a pandemic, and the interns of PGH are coming back. And next week, we're going to have deans from the medical schools in Korea, from the Seoul National University, and a dean from a medical school in India. So this is going to be very, very interesting. I would highly recommend that you involve your clerks, interns, ask them to watch the webinar, because we're in a pandemic and we need to continue to train doctors, and this is about how can we do it. So we'll see you next Friday when we talk about innovation and transformation for medical students. Raymond, over to you.
Thank you, Dr. Susie. And as mentioned by Dr. Susie, talaga pong bantayan po ninyo ang aming next episode. Hindi po virtual grand rounds ang ating episode for next week, but it's one of our special topics. It's actually a continuation of part 1 of our virtual international conference on medical education. The first part was really all about residency training, but for this one, we'll be focusing more on the medical school and the medical students po. You will see on the screen being flashed another round po for our post-webinar questions. So for those who are still with us in this webinar, please feel free to key in your answers just to be able to test what you learned for this webinar. Maraming salamat po ulit at mag-ingat po tayo lahat, lalo na po sa mga nasalanta po ng bagyo. This is Dr. Raymond Sarmiento signing off. Keep safe, keep healthy, and see you online.
The enemy remains unseen. I'll keep your hand in mine. Let's say a prayer one more time. I know you long for home, but I am here, you're not alone. I'll stay with you until the coast is clear. The others pain before my fears, the others laugh before my tears, but right behind the mask, I look into myself and ask, do I have strength to carry on? Oh God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. Just look into my eyes and say his name to realize it's fine to be afraid. Just hold on to the word he gave. This time will come to pass, 'cause this salvation's made to last. He'll carry you to see the break of day. The others pain before my fears, the others vows before my tears, but right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'm here to hold the line. I'll keep my word until my time. The others bang before my fears. The others laugh before my tears. But right behind the mask, I look into myself and ask, do I have strength to carry on? But God, how long must this go on? I need you here to keep me strong. I'll keep my word, your word is mine. The others pain before my fears. I'm pushing on despite the tears. Please take us through another day. Just hold my hand. I will hold the line. I will hold